So it is my privilege to introduce Dr. Romero. She is a clinical professor and director of the Brotman Facial Pain Clinic at the Department of Neural and Pain Sciences, University of Maryland School of Dentistry. She is a diplomate of the American Board of Orofacial Pain, a fellow of the American Headache Society. What did I just miss here? Fellow of the American Academy of Orofacial Pain and the American Headache Society. She has also been distinguished by numerous awards. One, which we're all very proud of, is the Stephen B. Graf Radford Orofacial Pain and Headache Lectureship at the American Headache Society. Dr. Grad Radford was an orofacial pain specialist in California who kind of led us as a specialty, as a group, into the world of headache medicine. So it's a great honor to receive that award. She graduated from the School of Dentistry at the National Autonomous University of Mexico and obtained her PhD in oral biology and orofacial pain and dysfunction with a certificate in such from UCLA School of Dentistry. She also did postdoctoral training in the neuroscience at the Goldberg Migraine Program in the Department of Neurology, that's a new name, at the David Geffen School of Medicine. So she did her orofacial pain residency and then did further study for like a year or 2 years?
3 years.
3 years? Okay. In headache medicine with one of the most well-respected headache medicine, Dr. Andy Charles. So Dr. Romero will be discussing neuropathic orofacial pain. So give her a nice welcome.
Hi, thank you very much for the invitation. Very happy to be here today. So the way I work with this talk, I'm trying to make it as digestible for you, that you get the most important information about neuropathic orofacial pain. So this is an introduction for you. So these are my disclosures. I have received grant support from the NIH, NIDCR, and NINDS, the Department of Defense, Amgen, and I'm the co-editor of Headache and Facial Pain section of Pain Medicine Journal, Oxford Academic, and I am the immediate PACE chair of the special section of TMD, cervical spine, and orofacial pain of the American Headache Society. So the way I prepared this for you, we're going to give an overview about, I know already we have discussed about pain neurobiology, but you're going to see I need to touch some points because it's relevant to the information I'm going to give you today. And we're going to be dividing neuropathic pain disorders in episodic and continuous. And I'm going to give you as well some clinical cases, not very long, but at least to give you the important key information that you need to remember. And I'm going to give my final remarks. So the goal of today is to give you the minimum necessary knowledge to assist you in detecting some of these disorders, at least the most common in the neuropathic pain realm, and to know when a dental pain is getting suspicious when we're talking about neuropathic pains. But the most important thing that I hope I can give you today is awareness. Because you need to understand that trigeminal neuropathic pain is a real condition and that the patient is experiencing pain, as well as the area of pain may look completely healthy and healed, but the patient is still experiencing pain. And so also the most important awareness of today will be that an incorrect diagnosis frequently will lead to unnecessary, irreversible, and invasive dental procedures in attempts to alleviate the pain, the symptomatology, but maybe it's going to make the things worse. So for trigeminal neuropathic pain, it has been estimated that the incidence of chronic orofacial pain, neuropathic pain, is 5 to 10 per 100,000 people. So neuropathic pain could be caused by a lesion of a disorder of the somatosensory system that is going to involve the peripheral component and the central component. You're going to see in my examples and the cases I'm going to be discussing today. But regards to trigeminal neuropathic pain, it can occur for different things, from root of nerve compression, nervous system disorders like neurodegenerative diseases, for example, multiple sclerosis, or idiopathically, or as a maladaptive response that can arise after sensitization from a nerve injury. And we're going to be discussing that today. That could be from dental procedures or injury associated to inflammation, infection, facial trauma, neoplasias, for example, or as a sequela of chemotherapeutic therapies, and some metabolic disorders. Pharmacological therapy is the first line of treatment, including anticonvulsant antidepressants, but we're going to be discussing a little bit more about that. So anyway, why this happened? Well, evidence supports that this maladaptive response to peripheral and central sensitization is associated with mechanisms involved in neuroplastic changes in the nervous system, leading to a dysregulation in pain modulation, favoring pain facilitation and maintenance. So what I would like to tell you about this. So I want you to think, normally I walk a lot when I give my talks, but here I can't, that the nervous system is very plastic. What I mean by that, because it's a very primitive system that we share with other species, has a wide degree of freedom. If you found in neuroscience terms and even anthropological terms is primitivism. That means that has a wide degree of freedom to change. So in neuroscience terms, what neuroplasticity means is the ability of the connection or synapse between two neurons to change in strength. How weak can be or how strong can be those connections. And this is going to influence by the changes in the amount of neurotransmitter release into the synapse and changes in how effectively cells will respond to those neurotransmitters. So if I'm telling you, and if you can see in this figure, let me see, can you see this? No. This figure, this is a very, I like to show it, maybe it's not sophisticated, but it's a peripheral terminal, and you can see that has different type of receptors. In more evolved systems in our body, mostly things are more specific. We have maybe one or two receptors, but the pain system, or at least in this peripheral terminal, you can see a lot of things are going on. That is this primitivism that I'm telling you. It's not that specific, the pain system. However, if you think about this, if I'm telling you this is plastic, if this plasticity, this wide degree of freedom that has to change is modulated by an environment that is harmful, and here I'm talking about intrinsic genetics of the individual that is influenced with epigenetics, right? Changes in environment can promote the establishment of something that we call central sensitization, or the term sensitization, and subsequently the enhancement of the pain cycle. So wrapping up this information, in neuropathic pains, when we talk about neuroplasticity and pain modulation that already you hear about in the first lecture today, we have an imbalance between inhibitory and excitatory signaling. We have alterations in ion channels, bottle-gated ion channels, but also glia modulation, and I'm going to tell you about that, as well as alterations in how the pain is received. I already was discussed to you about this wonderful intrinsic pain modulatory system that we have. So just to make a little bit more digestible the things for you, imagine that we have an ascending component and an inhibitory component. The ascending component is the one that is going to be receiving the pain. It's for the one that you're going to be receiving the pain, or how the pain is receiving your higher centers. Thanks God we feel pain. Think about it. Thanks to it, we have survived as a species. The problem is when this thing is getting maladaptive. Sometimes this ascending modulation in neuropathic pain, that means that the patient feels much more pain, and they call it, that could be a pronoceceptive profile, or also the other way altogether, this descending inhibitory system that is in very interesting nuclei in your brain, and the most important part will be the periaqueductal gray matter in your midbrain. Because of this neuroplasticity, it's not going to inhibit, and we call it this process of disinhibition. So you're going to feel much more pain because you don't have this intrinsic mechanism that is able to inhibit. So in neuropathic pain, a lot of things are happening, and this is part of, or at least part of my research, to try to understand what is going on or how this pain can become chronic. So as was mentioned to you before, just I want to mention briefly, because of the talk that I'm going to be giving you today, already Dr. Maram told you about the different pain fibers that we have, sensory fibers. But just briefly, A-beta fibers normally will not transmit pain, right? They are big, they are going to have bigger diameter, they're going to have myelin. The myelin is an isolator that is going to help how the stimulus is going to go from neuron A to B and C in a very organized manner. But it's proprioception, will not transmit pain. Hold that thought. So if I brush my teeth, or I touch my face, or I put makeup, will not hurt. Then we're going to have the two specific nociceptive fibers that will be the A delta fiber and the C. The A delta fiber is slightly malinated, medium diameter, is not as quick as the A beta, and will transmit nociception, pain, mechanical, thermal, or chemical. The C fiber doesn't have myelin, it's a small diameter, but it's going to also transmit nociception, mechanical, thermal, and chemical. And maybe you remember in your physiological classes, the first pain was the example that they used to tell us. You hit your thumb with a hammer. The first pain, is A delta, the slow and throbbing and the one that is telling you need to do something about it will be mediated by the C fibers. Action potentials. If you remember in your physiological classes, the action potentials is the way neurons are going to talk to each other. And it's a beautiful mechanism. Imagine that the neuron is an electrical capacitor. It's going to have a different voltage, and different neurons have different voltage, that they are orchestrated in different ways and parameters. So imagine that you're going to have this neuron, right? And the way that they communicate is electrical impulses that are going to be translated to neurochemistry, right? Neuropeptide release, or excitatory amino acids release, or inhibitory too. So we're going to have a threshold. Then we're going to have, depending on the voltage of the neuron, normally it's very negative. It's a stimuli, reaches the threshold for this particular neuron, and we have a phenomenon that we call it depolarization. That is a spike, is the way we see it, and then sends the information to the other neuron. An interesting thing that you're going to hear me saying when we talk about some disorders, the action potential has a refractory period and then a restful state. The refractory period, whatever you do or any stimuli you do to this neuron, you're not going to do anything. You're not going to be able to activate an action potential or more information, and I want you to hold that thought. So I couldn't, my plan was to show you a video, so I'm going to have it in my computer. This is a video of mine. This is calcium imaging. These are some trigeminal ganglion neurons. And I wanted to show you an action potential because you see the way we learn at the school is neuron A communicates to neuron B to neuron C. But no, it's a network of different types of neurons as well as other cells that we call them glia. So I'm going to show you. But this is a calcium imaging. It's a dye with stainless steel. These are trigeminal ganglion cells. And let me just show you. How can I show you? The problem is when these things become maladaptive in the cases of pain that we do see. So in addition of neurons, also we have glia. Let me see. Oh, yeah. Yes. So I want you to change the way you have learned about glia. the way they have told us that glia was only the cells that support the neurons, they eat the debris of neurons and feed the neurons. They have so much more functionality. So the glial cells are the immune system of your nervous system and have different types. And as well, when they get activated, they can release inflammatory substances such as cytokines, like your normal immune system. So glia is a regulator of neuronal function. And glia amplifies pain modulation and the excitability of your neurons. It can be in physiological stages, but as well as pathological conditions. So they are going to be enhancing pain, and they're going to be able to facilitate pain. So you see, we have neurons and glia. The current pharmacological approaches that we have, if you see, only work in neurons. So we need to do more research about that, and hopefully, maybe in 2 years or in a year, I can show you have something very exciting in regards to new pharmacological therapies for neuropathic pain to show you. Anyway, glia modulates pain, too. As was discussed before, just to give context to my talk, I know already they explained you this. Any pain coming from the craniofacial area is going to be transmitted to trigeminal, right? We have the trigeminal ganglion, that is your peripheral nervous system. Here, then goes to central nervous system, to the trigeminal ganglion, right? To the trigeminal nucleus caudalis, sorry. The causates to the contralateral side, and it's going to be processed to higher centers through the trigeminophthalmic tract to be processed in the somatosensory cortex. So, before we start the main thing about the talk, I want you to remember these important characteristics. Hyperalgesia. What is hyperalgesia? It's perceiving stimuli as more painful than normally would be. Imagine that if you cut your finger with a piece of paper, you know how annoying and horrible it is. Imagine that a patient with hyperalgesia will feel that somebody chopped their finger. And allodynia is perceiving normally a not painful stimuli as painful. And we're going to be discussing pain disorders that present that. So that will mean you brush your teeth, hurts you. You apply makeup, hurts you. So for trigeminal neuropathic pain, I just want to show you this. This classification also was work with Dr. Robert Merrill. You're going to hear about him, my beloved mentor, who passed away, I think, 6 months now. And I really like the way he used to explain us this. So you see, we have peripheral processes, peripheral nervous system, and we have centralized process, that is the central nervous system. In the middle will be the trigeminal neuralgia, because anatomically, in pathophysiological too, we can see that maybe something going on in the root that will be the link between peripheral and the central nervous system. When these neuropathic pain processes, either peripheral or central, things, if the sympathetic nervous system gets involved, things can get more complicated, can happen or not. So let's start to talk about episodic disorders. So I'm going to start with a case. As I told you, I just want to deliver to you the key information. So it's just little snapshots. So this is a 61-year-old patient with an history of pain in the left upper quadrant, localized in tooth number 14, present for the last month. The pain is described as a sharp shooting pain with electrical quality that lasts for seconds. This toothache does not wake up the patient during the night, and the pain is triggered while brushing his teeth and chewing his food. Pain comes and goes, and the patient reported that had a similar episode last year. The patient does not recall what precipitated the pain for the first time. The medical history is not contributory, the dental history is not contributory. So when the patient came with us with this pain, guess what? The tooth already was extracted, and the pain was without relief. So anybody would know what is going on here. I'm sure you know, but you're just too shy to say. This is trigeminal neuralgia. And I'm going to tell you something at the end of this segment. So the International Classification of Headache Disorders, as well as the International Classification of Orofacial Pain, gives you a very nice criteria to help you to make your diagnosis. So what is telling us? So, well, it's recurrent paroxysms of unilateral facial pain in the distribution of the trigeminal nerve divisions. I'm going to mention a little bit more about that. That is not going to be radiating, so it's mostly exclusively unilateral, and it's going to have these characteristics. So lasting from a fraction of a second to 2 minutes, severe intensity, electric shock-like shooting, stabbing, or sharp pain in quality, can be precipitated by innocuous stimuli, brushing your teeth, washing your face, talking, eating. And within the affected trigeminal distribution, we're going to have these trigger areas that I'm going to talk a little bit in the next 2 slides. And it's not better accounted by another disorder. So we're going to have common trigger areas that can be in any of the 3 branches, but normally will be almost common in B2 and B3, maxillary and mandibulary branch. And these trigger areas can be extraoral or intraorally located. So imagine if it's close to an area where a tooth or a teeth are, or in the gum. Another thing I wanted to tell you, this disorder has refractory periods. Remember the action potential I showed you? It's the same principle. You stimulate and you don't trigger it, then you stimulate again, and of course it's very variable between patients, and then you can elicit this horrible excruciating pain. Also, we have these remission periods that can be from weeks, months, or years. May have autonomic symptoms, but is rare, and I'm going to explain a little bit more about that, and can be paroxysmal, so it's only these episodes of sharp shooting electrical pain, or concomitant or accompanied with continuous type of pain. So imagine that the patient will report you like a background of pain that maybe could be dull, achy, sometimes burning, with these paroxysms too. Okay, pathophysiology. In regards with the ignition hypothesis, what is telling us? Well, and we have, some supports of evidence to say this, that is damage to the trigeminal nerve root that leads to partially damaged neurons. So we're going to have the myelinated areas, which are hyperexcitable and susceptible to ectopic discharge or excitation. And also we know that could be possible mutations of voltage-gated sodium channels. And it's the reason anticonvulsants reduce this discharge. So what is going on here? So imagine your nerves are going to be in a bundle, and the bundle is going to have motor and different types. But only let's focus about, for this example, A delta and A beta. Remember I told you that A beta will not transmit pain. It's proprioceptive. So what is going on? The ignition theory, and also we have evidence. Imagine that we have something that is causing demyelination, loss the myelin. Remember what I told you about myelin? It's this isolator that you're going to have in A beta, A delta too, right? But in case this A delta, we lose that myelin. So what is happening? So we have the bundle. So A delta, remember, is sharp shooting pain. We'll go like that. But then if we're in a bundle together, and we have loss of myelin here, in your A delta, imagine that these are more close. If the patient is brushing their teeth or applying makeup, the stimuli will jump and be transmitted through A delta. This phenomenon is called FAHS. So we have different types of trigeminal neuralgia. So one needs to be ruled out. So we have classical, secondary, and idiopathic. And each of them can be purely paroxysmal or with concomitant continuous pain. So the classical trigeminal neuralgia is when a blood vessel, the most common will be the superior cerebral artery, is compressing the trigeminal root. And, with an MRI, we're able to see this, to see if it's proper, or what they call it, optimal compression. Secondary trigeminal neuralgia could be due to different things. Some of this will be intracranial pathology, something that is going on in the cerebellopontine angle, like a tumor, could be an schwannoma or acoustic neuroma, as well as degenerative disorders such as multiple sclerosis, or other causes like arteriovenous malformation, or idiopathic. That means that we don't find a cause, why we haven't ruled out any classical or secondary source. I wanted to add this, that also to my students in the University of Maryland, and I stress to them, maybe for you will think like, oh, really? Well, rule out any possibility of any odontogenic cause, and I will say cracked tooth and cracked teeth. You don't have idea my share of referrals, even from neurologists, okay, and dentists that I have received of trigeminal neuralgia when actually was a cracked tooth. Maybe because the pain is zingy or can have that electrical type. Okay, you know, pain is very subjective, very personal. Trigeminal neuralgia has the tendency to be excruciating. But anyway, just if it's an intraoral trigger, think about the possibility of a cracked tooth. Anyway, for this, we need to send for a brain MRI with or without contrast to make sure to rule out any secondary cause or if it's classical, for example. So an MRI. If you talk to our colleagues in neurology, also they send for an MRA. So I want to show you this case. This case is from my time at UCLA. It's a case from Dr. Robert Merrill. And this was a 27-year-old patient that came to the clinic for a consultation, for a second opinion. She was diagnosed with TMD, and is the way it was referred to us. And, but you know, she hasn't had any optimal treatment. She was already taken care of by a dentist and a primary care physician. But the pain was only present when she was opening her mouth, and the pain was described as a sharp shooting electrical. And when she came, the examination was done, but was not, the joint was fine. Most of examination didn't trigger or was any tender or latent trigger point. Maybe came during a refractory period anyway. But was very suspicious and 27 years old. Trigeminal neuralgia you've seen in older patients. So Dr. Merrill sent her for a brain MRI, and was found an acoustic neuroma. Was sent to neurosurgery to do gamma knife, and the pain was taken care of. So very important, and I'm going to make some, maybe I can't mention today. So from our friends of neurology, sometimes they say, oh, how we can differentiate trigeminal neuralgia of TMD. For us, maybe it's very obvious. But think about it, that even could be some misdiagnosis if you don't know the diagnostic criteria. Think about it. It's not uncommon that patients that have trigeminal neuralgia, they're also going to be presenting some muscle spasm in the area of the trigger. The pain is so intense that the muscle is going to respond. Remember, they call it tic douloureux. So this could be a secondary muscle contraction or protective muscle contraction, but that doesn't mean it's TMD. The primary or the main diagnosis trigeminal neuralgia, just the muscle is responding. So just I wanted just to mention, because I guess for us, it's very clear the differentiation of each disorder. How is managed? Well, the only FDA-approved medication for the management of trigeminal neuralgia is carbamazepine, Tegretol. But the ones that I'm going to mention again as, as in headache, some of the medications for headache that Dr. Bender mentioned is off-label. So the first line is medications, and surgical intervention is reserved when there is inadequate pain control and poor side effect tolerance. And I'm going to mention a little bit more about the anticonvulsants that are used, but for surgical management could be gamma knife, radiofrequency ablation, as well as microvascular decompression that I'm going to be talking today. So manage trigeminal neuralgia, anticonvulsants. So think about it. Carbamazepine, at least we have information that will work in sodium channels, but these drugs, work in a lot of different things. Calcium. Even some people say that I think oxcarbazepine even can modulate GABA, that is inhibitory neurotransmitter. Anyway, so imagine that, remember the action potential that I showed you. Action potentials are very well orchestrated and very organized. And if you see a patient with epilepsy, the action potentials are just crazy. Of course, it's the motor cortex, whatever. But with the same concept, imagine that these action potentials in this type of patients are disorganized. And these drugs, these antiepileptics, are going to try to normalize or increase the threshold, right, of this voltage, so you're not able to, to stimulate. I hope that makes sense. So we have carbamazepine, oxcarbazepine, these two drugs. For example, carbamazepine, gold standard in management. We need to be careful because can cause different problems such as anemia, thrombocytopenia, and we need to send the patient for a CBCT and differential, as well as liver function test, so we need to monitor the patient. And oxcarbazepine is the one that I will say is better to start, but depends on the patient too, medical history too. We need to monitor sodium because it can cause hyponatremia. And let me see, did I put it here? No. I just wanted to mention, maybe because I used this one and I didn't save the new one. Anyway, botulinum toxin injection has been shown that could be a good adjunctive therapy for the management of trigeminal neuralgia. And if it's the trigger intraoral and extraoral, of course, we don't have a standardized protocol. And but will be, and I think Dr. James Hawkins just published one paper maybe a couple of years ago about they use for some cases that he had for trigeminal neuralgia, but you're gonna see it in the literature. So will be, it's a good adjunctive therapy when your patient, starts to have side effects. Maybe it can be medication. Maybe the patient, you cannot titrate a lot because side effects are arising. Maybe you can add an adjunct therapy, such as botulinum toxin or even sometimes some nerve blocks. Anyway, very important. The use of these medications can increase the risk of toxic epidermal necrosis and Stevens-Johnson syndrome in patients that have these different type of HLA alleles. And these in patients in Southeastern Asian ancestry, so it's necessary to, that you have some screen. So the management for case number 1, the brain MRI with and without contrast in this patient I mentioned was clear. So we don't have also we didn't find vascular compression or secondary source was detected. So which was the diagnosis? Don't be shy, come on. Wait, Dr. Bender, right away you guys knew what is going on. This is an idiopathic trigeminal neuralgia, purely paroxysmal. So we treated with oxcarbazepine, 1,200 milligrams a day. We monitored sodium levels. They were fine. Medication was well tolerated. And now, since this time, this was an old case. But now, if I would have had this patient seen, I think it was 10 or 15 years ago, this case. But now maybe in the area of trigger, if I were able to delimit it, maybe I would be doing a botulinum toxin injection there. Also Dr. Don Nixdorf and Dr. Aurelio Alonso, I think already they have mentioned them in the talk. They have a very nice, who was also Dr. Babiloni, I think. They had a very nice paper about cases, and they mentioned the dosages that they use. I think was in the literature from 17 to 20 units per area in 0.05 cc slide. Okay, anyway, it's very variable, but I will consider in those cases. Differential diagnosis. So, with Dr. Bender, you learn about trigeminal autonomic cephalalgias, these primary headache disorders that are going to have profound autonomic symptoms. So it has been said, and it's in the literature supported, that from the trigeminal autonomic cephalalgias, the short-lasting unilateral neuralgiform headache with conjunctival injection and tearing, the SUNC syndrome, and SUNA, that is the short-lasting unilateral neuralgiform headache with autonomic symptoms, are a continuum with trigeminal neuralgia. It has been shown in the literature that also those patients can have some vascular compression similar to classical trigeminal neuralgia, but at least I want to show you with this the differences, because the pain will be sharp shooting, but normally will be localized in B1, as the case that Dr. Bender showed to you. A difference in trigeminal neuralgia will be B2 and B3. But the most important thing is that these patients are going to have profound autonomic symptoms. If in trigeminal neuralgia, if there is some autonomic phenomena going on, it will be rare and very mild. The most important thing is that SUNC and SUNA, we're not going to have this refractory period whatsoever. And trigeminal neuralgia, we do. But the most important thing, think about it. Well, I'm telling you that B1 is SUNA, right, with autonomic phenomena, but what about if you have profound autonomic phenomena in the area in midface, B2 and B3? Well, the International Classification of Orofacial Pain has the orofacial pain resembling presentations of primary headache disorders, as Dr. Bender mentioned to you. And we have a trigeminal autonomic orofacial pain, and we have the short-lasting unilateral neuralgic from fascial pain attacks with cranial autonomic symptoms, or SUNFA. So remember, differential diagnosis between these disorders: profound autonomic phenomena in SUNC, SUNA, and SUNFA, and then we're going to have this refractory period that we found in trigeminal neuralgia. The good news is SUNC, SUNA, and SUNFA can respond to antiepileptic therapy. Anyway, as trigeminal neuralgia does. So briefly, yes, the most common neuralgia in the craniofacial area will be trigeminal neuralgia, but we have different ones. We can have glossopharyngeal neuralgia that will be the same sharpshooting electrical pain, but localized in the area where the glossopharyngeal nerve is innervated. So it will be the tonsils. The patient will have pain when it's swallowing, but it will be the same protocol: MRI and antiepileptic therapy. Just to mention briefly, other neuralgias could be nervus intermedius neuralgia, mediated by the nervus intermedius branch of the facial nerve, pain inside the ear. We have occipital neuralgia. We have, of course, postherpetic neuralgia. The theme of neuralgias will have their own, talk about that, but we need to talk a lot about other things today. So now let's jump to continuous disorders. So let's do clinical case number 2. So this is a 45-year-old patient. That pain started after periodontal surgery 4 months ago. The pain is localized in the buccal mucosa in the lower right quadrant in number 29 and 30. The pain is continuous and variable from the scale 0 to 10. 0 no pain, 10 the worst pain. I will need to take the pain. As I told them like that, I need to take you to the emergency room with that perspective, 4 to 5 out of 10. The pain is aching and burning and is worsened by touch. So no periodontal lesions, no dental indications, normal radiographs. So what we did, gently pushing and touching the gingiva significantly exacerbated the pain. So yes, we have allodynia there. And then we really dry the area with a cotton, and we apply 20% benzocaine. And we relieve the pain to 0 for 2 minutes. And then we did an infiltration in that area, and we relieve the pain to 0. So we have this burning pain. It started 4 months ago after periodontal surgery. And this is a continuous type of pain. Anybody has an idea what is going on? But I guess you're tired or you're too shy. Did I make you shy? Please no. Okay, this is a peripheral trigeminal neuropathy. Because we were able, and I'm going to mention, to block the pain in this neurosensory test that we did, this burning pain that the patient presented, and since it was after a dental procedure, this is considered depending on the classification, international classification of headache disorder, or international classification of orofacial pain, you're going to see the criteria is very similar, but will be post-traumatic trigeminal neuropathy. So, remember I mentioned we have peripheral process, a centralized process. In this case, we were able to block the pain, the peripheral input at that area, maybe with a topical or with an infiltration in that area. So our patient had a response to somatic or local anesthetic blocking. So what is this post-traumatic trigeminal neuropathic pain? Well, as I mentioned to you, is pain due to an injury. It's a maladaptive response presented in the orofacial region that can arise after sensitization from nerve injury. And I will say, since we are here with you guys, most of you are general dentists, it's not very common, but can happen. And this could be in response to extresal trauma or iatrogenic injuries from procedures such as orthodontic surgery, dental extraction. The most common will be third molar. Oral surgery, dental implants, and I think the ones that with orofacial pain we see our share of cases, unfortunately. Local anesthetic injections, the most common is inferior alveolar nerve, and root canal therapy. And pain is present with other symptoms and clinical signs of trigeminal nerve dysfunction. And what I mean by that could be, imagine, not only neuropathy pain, also could be negative symptomatology. We have positive is the painful one, but negative could maybe also numbness too, in addition with the pain. We call it dysesthesia. And these symptoms can be persistent or recurrent for more than 3 months. And these patients have the unfortunate history of multiple and repeated consultations with different providers. Maybe they already have, in attempts to resolve their pain, other dental procedures, happening. It's not uncommon that we receive cases that was a root canal and was a retreatment, and then an apicoectomy, and then extraction. And then they just started to do with the other root canal, for example, in the contiguous tooth. So what happened here? What is the pathophysiology? Well, remember, we have sensitization. In neuropathic pain, we see this hyperexcitability, either peripheral or centralized processes. So we have an abnormal nociceptive sensitization. So the peripheral, I wish I could show you what I can. Anyway, or I can? Anyway, I don't want to move anything here. Okay. The peripheral nociceptive terminus gets sensitized after trauma. But what your body tries to do, your body tries to heal, but it does it in a disorganized manner. So it's going to form neuromas. And if you see neuromas, it's just disorganized neuronal tissue. But your body really tries to heal, just does it in a disorganized manner. So during regeneration, neuromas are formed and are subjected to ectopic discharge. Remember we talked about this ectopic discharge with trigeminal neuralgia, because imagine if it's something compressed and we lost myelin, it's kind of the same principle here. This ectopic discharge can happen at the level of the whole peripheral nerve to the trigeminal ganglion area. And since we're in a process of regeneration, we're going to have a regulation of a lot of different things. So from nerve growth factor, for inflammatory mediators, but of course for simplicity and importance, because I'm going to mention something, we're going to have a regulation of sodium channels in the area. It's the reason if you find a neuroma, and sometimes even intraorally, you can do a tiny T-nail sign. You can infiltrate a little bit of a lidocaine, right, a sodium channel blocker, and we can decrease the pain. So this activation is going to decrease the threshold of pain. Is the reason your patient is going to have allodynia and increase the pain cycle, of course. So how we manage? We can use systemic medication, like tricyclic antidepressants, anticonvulsant if the patient has background of pain but has also sharp shooting or needle-like pain, SNRIs. We can use also botulinum toxin type 8 injections. Or we can inject in the area corticosteroids. Sometimes analog 10, a tiny little bit can be helpful. But we can use topicals. And I'm going to mention in the next slide from capsaicin, lidocaine, benzocaine, tricyclic antidepressants, different membrane stabilizers, antiepileptics. I just want to mention here surgical interventions. For peripheral, in the literature you're going to find that could be maybe microsurgery can be recommended in certain cases in patients that have, a specific type of from the localization, the area, mostly when the injury is in inferior alveolar or the lingual nerve, could be an option that should be discussed but should not be, taken lightly. And that will be for very specific case, and success are variable and carries risks and challenges. And as in any chronic pain, behavioral interventions to support the quality of life of your patient, of course, are very important. So I told you about topicals. Remember, this is something that you can do when you have suspicious and the patient is telling you it's burning, tingling, I feel like needle or something crawling. You can do this test. So it's a local infiltration or a local anesthetic block. Of course, you ask your patient if it's 0 to 10, how much is the burning decrease when you do this block. And that will tell you that if it's to 0, could be useful to also offer in your therapy topical medications. So we're going to talk about central cases too, central neuropathies. But for example, if your patient has pain at 7 and you did a local infiltration, and the pain goes to 3 or to 2, so it's still, it's completely anesthetized, but it still have some pain. Maybe the pain is in the middle, it's centralized, but maybe you can offer topical therapy, topical approaches, as well as systemic approaches. And I'm going to tell you, sometimes with that type of therapy, you find yourself that you don't need to bring your patient to higher dosage of systemic, that you can, because you are blocking peripheral input from the periphery. Anyway, topicals, how we do. So for burning type of pain, we use capsaicin. Could be from 0.025%. Could be variable, but the dosages, and we can mix with Oravase, so you can still find it, or in a compound pharmacy can do it for you, or with lidocaine 5%. And you will say, well, why are you going to do capsaicin in a patient that has burning pain? Well, we're going to activate the transient vanilloid receptor potential receptors that are the, capsaicin, is the active substance of the Red Hot Chili Peppers. So you activate that, imagine in your C fiber, and this is going to help the granulate, is what we're trying to do in lay terms. The granulate, whatever that C fiber needs to spit, if it's substance P, if it's CRP, et cetera, et cetera. It's kind of the principle that we do. Will hurt. That is the reason we mix it with an anesthetic. And we do a neurosensory stent that we're going to apply the topical close to, so the patient can put it in and apply it there and leave it there 3 to 4 times a day. Of course, depending on the protocol, we tailor the protocols exclusively for the needs of the patient, but also we can add different type of topicals in the compound. Could be from anticonvulsants, could be tricyclic antidepressants, for example, in the compound of the cream that we're doing. So now, where this is peripheral pain, now we're going to do clinical case 3. This is a 45-year-old patient that presented pain for the last 2 years in the upper right quadrant, and this pain started in number 5 in the maxillary first premolar area. So this patient came to us with a history was like this, had a big incrustation, and started to develop pain, too hot, cold, sweats. The pain sometimes could be spontaneous at night. So it was diagnosed with irreversible pulpitis, and yes, there was a root canal done, and the root canal was indicated. The problem was that at least the patient was, what he told us, this root canal was done in a school, and looks like was not very compliant, the patient, to their appointments, so the root canal the procedure was very protracted. And so looks like after the root canal was finished, was 1 week, and the patient was very happy, but the pain came back. So was decided to retreat that tooth, and the retreatment didn't give any relief. And then the patient started to say that, you know what, now number 6, the canine is hurting. So you see, we have this phenomena here. We have expansion of receptive field that I'm going to explain in the next slides. So number 5 got extracted, and of course, it's more elaborated, the story, but just for time I'm kind of too compacted. And the pain is present, constant for 24 hours, burning, dull, aching, moderate in intensity. And so that was the case. And when we did a neurosensory test, a local anesthetic block was performed and produced an equivocal result. Doctor, I feel numb, but I still feel the pain. So from 7 went to 4. So now we have, an equivocal response. So this is a centralized process. So the diagnosis here will be a centralized trigeminal neuropathy. Also, this is a post-traumatic trigeminal neuropathy, and is characterized by ongoing persistent aching, burning pain. I will add also here, sometimes even can have a superimposition of kind of lancinating needle-like type of pain sometimes that does not respond to topical or local anesthetic blocking. So what happened here? Remember, you hear me saying about neuroplasticity, these central changes that can happen. So the process of central sensitization, we talk about trigeminal pains, is going to happen at the level of the trigeminal nucleus caudalis. So there we're going to have second-order neurons that are different types. the most common ones, or maybe the ones you have here, is the wide dynamic range neuron. And as I mentioned to you, they're going to be working in networks. So when we have a stimuli that is in such an strength, or we have this hyperexcitability that is ongoing, can activate the second-order neurons that are at the level of trigeminal nucleus caudalis, and the process of central sensitization at this level is going to cause different changes, and one of those is this increase of the receptive field. So it's this kind of referral, regional referral. And it's the reason maybe these patients can tell you, well, you know, I feel is this tooth, but now, doctor, I feel it here and here. It's for that phenomena. When the pain is described as I told you, burning, tingling, sharp, shooting, blah, blah, blah. Anyway, another thing that I would like to tell you, when central changes happen, also we have anatomical changes. What I mean by that, I think briefly was mentioned to you in the first lecture about interneurons. Interneurons, the majority will be inhibitory. In cases of chronic pain, you lose, the interneurons lose the capability to inhibit. In addition to that, we're going to have physiological changes, this new rearrangement of networks. And I guess the way I see it, my humble opinion is that our body just trying to, it's a constant alert that something is going on, and it's trying just to use all their capability to make sense of it, higher centers, and to try to block it, but just does it, it's trying to do it in a disorganized manner. Anyway, changes in neurochemistry. As I mentioned to you, yes, it changes in the quantity of inhibitory neurotransmitters, maybe GABA that we know is inhibitory, maybe it's less, or increase of excitatory neurotransmitters such as glutamate. In addition to that, could be related to the intrinsic genetic of the patient and their ability to accept epigenetic changes that in this case could be harmful. So all this is kind of a view what will happen in the trigeminal nucleus caudalis for the second order neuron. So we have this release of neurotransmitters that are going to activate postsynaptically. So other type of receptors can be recruited at this time, such as the NMDA receptor, can be a phosphorylation at that level, as well as the AMPA receptor. And again, I want to emphasize, yes, it's neurons, but we have glia modulation. It's super important. That helps just to amplify all this stuff that is going on and decrease the pain threshold to stimulation. So management. We can use tricyclic antidepressants. They are good for continuous time of pain. We can use some anticonvulsants, SNRIs. We can add topicals. Injections of an botulinum toxin type could be good as an adjunct therapy. Anesthetic blocks also can be good for adjunct therapy. But I would like to say, and I think for all of us, and now that you're interested in orofacial pain, that I think in the academy makes us very happy, the management is not an algorithm like we see in dentistry. It's tailored to the patient, and you're going to see, and one of the frustrations, I think is one of my interests that I do research, because I'm very interested in repurposing drugs that we know that are safe, to see that effective in pain, or to discover new targets, is that currently for neuropathic pain, the medications that we have, of course, not optimal, because maybe we can increase or taper up one medication that is helpful, or we need to add another medication to make both of them work better for pain control, but then the side effects start. So now we have the dilemma. Okay, I give you the drug that is helping you for the pain, but this drug is decreasing your quality of life. So that is a big dilemma right now that we have, I think, in neuropathic pain, and I will say, well, most chronic pain disorders. I just added here surgical interventions that I will say they're reserved when there is inadequate pain control and poor side effect tolerance, but this will be kind of the same protocol that I will do for trigeminal neuralgia. But, again, it's case by case if ever is necessary. And, of course, behavioral interventions like cognitive behavioral therapy and other support, type of support like this for your patient. Of course, my talk will not be complete if I don't talk to you about persistent idiopathic facial or dental pain. So this was previously known, and of course is still a diagnostic category, right, atypical facial pain. So the International Classification of Headache Disorders and the International Classification of Orofacial Pain, now finally we have at least a criteria to help us categorize these disorders. And it's a term that is applied when any other source of pain has been ruled out and no absolute mechanism can be determined to be assigned into another diagnostic category. So this is orofacial pain that occurs in the absence of any neurological deficit or any other obvious etiology. And is described as a dull, aching, deep or superficial. This pain is very diffuse and may not follow neuroanatomical distributions and may present slight subjective sensory disturbances. And you're going to see is considerable overlap of the neurophysiological and sensory abnormalities that we see for trigeminal neuropathic pains. And right now we don't have like a protocol on how to manage, and there are very few randomized controlled trials that really have explored that. So we treat them the way we do neuropathic type of pains, with the same medications that we use, and of course non-pharmacological approaches too. So I want you to see this panorex. What do you see in this pan, even though it's obvious? All root canals. This panorex is from Dr. Tony Schwartz. I have his permission to use it, and I really like to use this because just you see, they say, oh my God, what happened here? So this is the cases that, what about, yes, forget about unilateral, trigeminal neuralgia that you're trying to resolve with dental procedures, or in this case, persistent dental-alveolar dental pain. And I think even though you don't know about orofacial pain, I think it's a way as a dentist that you will say, it's your judgment. You say, stop, I'm just doing this, and it's not helping the patient. But the way we're trained in dentistry is, right, we resolve pain with dental procedures. But it's a moment, right? And you see, I think here they have stressed you out the importance of the medical history, the questions that you do. Because even if you don't know about orofacial pain, you say, no, I need to stop. But look at this. Anyway, persistent dental-alveolar pain. It's a chronic pain condition that presents as a persistent tooth or teeth pain or pain over a dental-alveolar site formerly occupied by a tooth in the absence of any detectable pathology during a radiological and clinical exam. Unfortunately, patients may undergo several dental procedures in hopes of relieving their pain. We have a criteria in International Classification of Orofacial Pain, and this was the pain that used to be known as atypical odontalgia, phantom tooth pain, or primary dental-alveolar pain disorder. So it's persistent unilateral intraoral dental-alveolar pain, rarely occurring in multiple sites with variable features, and should be for more than 3 months in the absence of any preceding causative event. If the patient reports to you that had a surgery or dental procedure, according to this criteria, this event should have happened more than 6 months. If it's less than 6 months, it's diagnosed as a post-traumatic trigeminal neuropathy, and may be present with and without somatosensory changes as determined by qualitative and quantitative sensory testing. So, about these idiopathic facial and dental-alveolar pains, you see the diagnosis is of exclusion and should be made after other local systemic or other sources of orofacial pain have been ruled out. And it's not very uncommon that as orofacial pain specialists we receive this atypical facial pain. And I will say this, and I think my colleagues, my orofacial pain colleagues are going to agree with me. Sometimes we discover that actually this atypical facial pain was Eagle syndrome, or this atypical facial pain was actually myofascial pain, or this atypical facial pain was a primary headache disorder. So orofacial, pain resemble headache disorders, like an orofacial migraine, for example. And these patients have already seen multiple specialists in attempts for a diagnosis for better management. So bottom line here, the need of a thorough, and I know they have stressed you this, but you see how important this is. The need of a thorough evaluation and history to rule out the possibility of other orofacial pain disorders is crucial. And the clinician needs to be aware of other possibilities, right, orofacial pain that may not have been considered into differential diagnosis. So finally, of course, at least I need to tell you a little bit about burning mouth syndrome. So it's Also, in the international classification of orofacial pain, is in the category of idiopathic facial pains, and is characterized by unremitting oral burning in the absence of detectable oral mucosal changes. The literature and the evidence, and my humble opinion, I see that this could have, I would say, it's neuropathic, but it's still, some controversy if it's not. It's the reason I wrote possible neuropathic pain condition with peripheral and centralized components. Would be most of the time bilateral, symmetric distribution, and the common areas would be the tongue, the 2/3 anteriors of the tongue, dorsal and lateral borders, and could be due to primary and secondary causes. Primary is idiopathic, secondary could be local and systemic. Local, we can work with our friends and colleagues of oral medicine, right? If the patient reports to us tobacco use or a candida infection, even GI reflux can give some burning sensations. If it's any mechanical type of the patient is just constant moving their tongue. Patients with tardive dyskinesia or oromandibular dystonia, sometimes you can see them that they can present this symptomatology. Or a lesion from lichen planus, leukoplakia, neoplasias pemphigoid, stomatitis due to allergy. And the systemic autoimmune conditions, Sjogren is one, diabetes mellitus, hypothyroidism, menopause, Helicobacter pylori, and some medications, but also I will say nutritional deficiencies such as, and here I didn't write it up, vitamin D, D3, serum ferritin when it's high, and B complex levels. I think it's B1 and B6, and I think B12 too, and zinc. Anyway, so management. For idiopathic primary, topical analgesics and or anxiolytics, clonazepam rinse could be helpful, but it's tricky to treat these patients. And in the literature you're going to find tricyclic antidepressants, amitriptyline or tryptophan, but also they can cause dry mouth. So again, you have a medication, yes, no? Benzodiazepines, if they can, I forgot, there is one that they can do and suck the tablet, I forgot. Anyway, anticonvulsants, there are protocols with gabapentin and alpha-lipoic acid. In some patients I have used it and has been helpful. Alpha-lipoic acid is antioxidant, so that tells you what is going on. This disorder is one of the disorders that I'm thinking maybe it's a problem of homeostasis of free radicals. Maybe we'll be from another talk. Anyway, and cognitive behavioral approaches. And if it's secondary, you're going to be targeting the disease. Anyway, behavioral neuropathic pains, just to finalize. Electric shock, sharp shooting, bright, prickling, tingling. They have the aching component too, but you see it's kind of, I will say, even though it sounds redundant, this nervy type of component. So my final remarks. So trigeminal neuropathic pain can be devastating for the quality of life of the patient and require a careful diagnosis and management. The pain experience is very subjective, so for some patients it will be very difficult to really express to you, the type of pain that they're presenting. So you will use words like the burning, you can say, so you feel like fire. I use the word for electrical shock, sometimes they get it, but say it's like a thunder in your face. Yes, doctor, those type of things. It is essential to emphasize prevention and avoid unnecessary dental procedures, and that is the reason that since you're a general dentist, ask for advice, a second opinion. And now we're very happy to have you here with us. Because from that, already, even though if you start to learn this, but you start already to have your judgment that, no, this I cannot do, another root canal, or this is very suspicious. I'm going to send you to somebody that can give me a proper opinion. And now you have us. So you can ask for advice to us, a board-certified orofacial pain trained dentist, and never underestimate second opinions. Like I say to my students, you take your ego out, because there are plenty over there, and just ask. And when the pain is already established, it is crucial to manage it in a multidisciplinary manner and provide understanding and compassionate and effective care when you can. The best possible we always strive for, and support for the patient. And before I finish, I'm going to tell you a story, since you are interested in this. And this is me with my thing. I always put this from my Day of the Dead custom. So now that you're interested in this field, and now the academy prepare for you this wonderful course, people ask me, okay, why you study orofacial pain? For me, it was a calling. I felt that I just was interested to take care for this patient population. And one of the things was that I saw a patient with trigeminal neuralgia, and already was almost the full quadrant extracted. And for me, it was like, oh my God, like was I think one premolar there only. And for me, it was like extra, everything, and was nothing wrong. And my professor, no, this is not dental anymore. And the patient was like, no, but this, please take it out. No. He prescribed medication. Of course, we sent it to the doctor for the regular protocol. And for me to see that a medication, right, took away this dental pain, and how the patient was, again, smiling. Of course, this was a wonderful experience, for me to see that this knowledge you see so powerful. We can help a lot of people. Students tell me, also the question, yes, you're not going to do as much money as ortho, prosto, surgery, but you can help so much people. And depending on whatever is your area, as a general dentist or endodontist, this knowledge is super, super knowledgeable to help these type of patients and to help in the prevention. Anyway, it was a pleasure, and I hope I didn't make you dizzy with all this information, but thank you very much.